My hot take is if your medical history reads like a novel, please bring the book.
Welcome back to episode 5 of Blink Collective. I'm McKenzie, and I'm joined by my co-host and optometry school bestie, Lisa.
Hi, everyone. Thanks for tuning in again.
And Lisa, I cannot believe we're already on episode 5.
I know, I feel like we just recorded our very first episode not too long ago, and now
I know.
we're already here.
I know. And I mean, we've had so many new listeners join us recently as well. So I thought this would be a good kind of opportunity for us to remind everyone why we're here and what Blink Collective is all about.
Yeah, absolutely. So Blink Collective is a podcast sponsored by Valley Contax that aims to connect optometry students, new grads, and practicing doctors through real conversations about clinical care, career development, and everything else in between. We're here to learn together, share experiences, and also build a stronger optometric community.
Yeah, of course. So if, there's a topic you want us to cover, like we always say, or you have seen a fun or an interesting clinic case that you think others could learn about, or if you just want to join us for an episode, we would love to hear from you. So please reach out.
Yeah, we want more voices, more perspectives, and more conversations from all corners of optometry.
Yes, I couldn't agree more. So, Lisa, you texted me a few days ago and said that you had thought of a hot take for this episode. So I think it's time to jump right in.
Yeah, I guess we're really going to do it here.
Yes. All right, let's hear it.
Okay, so my hot take is if your medical history reads like a novel, please bring the book.
Oh my God, yes, it's so annoying. But I feel like if you're like a medical provider or maybe another optometrist, and we would probably get annoyed by this too, you don't agree with this hot take.
Yeah, yeah, that's so true. Most patients are just, I don't know, they're just not great historians.
No, they're terrible historians.
Yeah, and I mean, honestly, I don't blame them. I mean, if you've seen 5 different doctors over 10 years, had multiple surgeries, tried countless medications, and been diagnosed with conditions with names you probably couldn't even pronounce, which happens a lot in optometry.
Yeah.
I guess it is unrealistic to kind of expect for that patient to remember every single detail about their care in the past.
Yeah, for sure. And I feel like sometimes maybe there's optometrists out there that don't explain it as in detail that obviously when you I feel like I don't think about that. I just try to explain it in layman's terms to the patient.
Yeah.
But I don't think about, if they're going to go see someone else, then they might not be able to share that, what I'm actually trying to say.
Yeah.
But, it is hard to expect them to remember because I barely remember what I ate for lunch yesterday. I don't even know if I ate lunch, so I get it.
Yeah, literally same. But no, I kind of agree. Some providers, I've had patients come in, they're like, I never even knew I had this, or my past eye doctor never explained this to me. So I think it's kind of hard because you don't know,
You don't know what was going on.
Yeah, exactly.
Everyone is so different.
Yeah, yeah. And from the provider side, it can make an appointment incredibly inefficient, which is so frustrating.
Yes.
We spend valuable time trying to piece together a medical mystery from fragments I had a laser done a few years ago, or I used to take this drop with a blue cap. That's my favorite, is they always remember the cap color, which is helpful. It really is. And I'm like, oh wait, now I got to remember what drop that is. But
yeah,
that's usually,
I know. Or also, I really hate when, I'm asking the, medical history from the family and stuff, and I ask if anyone has had glaucoma. And everyone always says yes, but then they didn't have glaucoma. They had cataracts.
Oh, my
and
God.
That is,
the amount of times that people, because that same thing happens to me, so I'm assuming this happens to literally everyone.
Yeah.
But you ask, do you have any family history of, eye diseases, glaucoma, macular degeneration, things like that, blindness? They're like, yeah, I think someone had cataracts, and I'm like, all right, moving on, because that's just
I know, but they always get it confused.
They think it's something genetic.
And so then I have to keep asking all these questions and going into everything. So if we just had a little printout, maybe it would be a little bit better.
Yeah.
But
Yeah, I think the one thing that patients get most confused by is cataracts. They're like,
Yes.
they don't think that everybody gets them if they live long enough, and
I
I
know.
think that's
And
the
then you start
biggest.
asking more questions and they can't answer those questions because they
Yeah.
don't actually know, obviously. But, the patient always is looking at us like we should already know the
Mm-hmm.
answer that they're trying to tell us
Yeah.
or what they're asking
Yeah.
us when we don't. So,
Yeah. Having records available to like help us provide it helps us provide like better care,
yes.
avoid repeating tests,
Hmm.
especially understand what's been tried before, what works, what doesn't work, and to help make like safer clinical decisions. And it
Yes.
saves time for everyone involved and reduces the
Yes.
chances of just the important information getting lost. Like,
Yes.
what patient wants to be put through an unnecessary visual field? Like,
No
everybody
one.
hates visual fields.
They hate them because it is the most boring possible and hard. That test is a hard test.
It is. I
Like
mean,
when we took it in school for like the training class or whatever, I did really bad on that.
oh yeah, I don't blame patients for not liking it because I hate sitting through doing like a
Yeah.
visual field test. Like it's not the most fun thing to do
No.
at
No.
all. And I have that like blackout on the second eye.
Yeah, so do I.
And so I can't see any of like whenever they do my left eye, I'm like I can't see anything.
I know it's so scary, but at least like I guess the headsets, the like virtual ones are
Yeah.
like a lot faster, so hopefully that'll kind of cut down on some of it
Yeah,
too.
those are really great. I feel like patients like those a little bit more.
Yeah.
I mean, still not like the most fun, but
No, but it was also really funny when they're like sitting in the waiting room, just all these like old people with gray hair and they have on like
the little people,
headsets and
they're just
I'm
like blinking.
done, I'm done.
I know, that is funny. But it is nice for also like someone who like can't get into the visual field machine too.
Yes,
So,
yeah, that's very helpful.
yeah.
So I don't know. I feel like when patients bring in records or at least know kind of where they've been seen,
Yeah.
what procedures they've had, it makes life easier for everyone because we're not having to run back and forth to the
Yeah.
front desk asking, "Oh, can you call these to fax these records?" And then they were
Yeah.
like, "I've never seen that patient before." I'm like,
Yeah.
"They saw nothing wrong there." So
Yeah, and I think a lot of patients kind of just assume that their records like kind of follow them
yeah,
everywhere.
yeah,
But it's just like not the case. There's different offices use
yes,
different EHR systems, and then
hmm
the record request that takes time, and some things just
yeah,
don't get sent before the appointment, or it's just a huge long process that isn't always the most fun and
yeah.
takes some time for you to even get that information.
I know. So I don't know. I guess like we said, we're not really expecting anyone to carry around a gigantic binder with color coded tabs,
That would be
which
like,
that would be good.
yeah.
I like that. I love a good color coded tab.
Yeah, if you're super type
Um,
A like us, then, you know.
it would be great.
Yeah.
But even, it's fine. Just do your best, I
Yeah.
guess.
Yeah. Yeah, literally. Yeah, it's, you know, I mean, even having like a list on your phone though, I feel
Just a
like
simple list of your medications would be fine.
yeah, and I know for like people like in our generation, that's probably a lot easier to
Yeah,
do.
for sure.
But because I know a lot of like of my older patients, you know, you've probably experienced this too. They carry like a medication list, which is great. Like have a
Hmm.
little like printed out sheet in like their wallet or their
Yes.
purse, which that's always great.
Hmm.
But yeah, now that like we have our phones and they can hold endless amounts of information, it's always
Makes it a lot
yeah,
easier.
yeah,
So I guess, like, moral of the story, you don't have to memorize your entire health history. You
yeah,
just need a way to access it, pretty
yeah,
much.
yeah, yeah. So my hot take stands: if your medical history lead reads like a novel, please bring the book.
Or just the clip notes
Yeah,
would be fine too.
Cliff Notes works too. Help us help you.
Yes, exactly. And then your appointment won't be over an hour long because we spent 40 minutes of that trying to dig up your history.
Yeah,
So it's fine.
yeah,
All right. Next, we really wanted to talk about a powerful case
yeah.
that we were able to read about through the Valley Contax Custom Stable Vision Project.
Yeah, I feel like this one was a really like great one and just shows
Yeah.
how much of an impact just a scleral lens can make in a patient's life. McKenzie, if you want to give us like a little bit of a backstory on this
Yeah, I'd love
case.
to. All right. So this case is on a patient with
Mhm.
ALS. And for those of you out there that know a little bit about it, you know that it is a terrible
Yeah.
disease. So obviously maximizing patient comfort
Yeah.
and making their ADLs easy for them are pretty much our top priority.
Yeah.
A little bit more on the patient. So they are paralyzed from the neck down, but they are able to still move kind of their eyes
Mhm.
and they're able to blink intermittently. So
Yeah.
not as much as they need to,
Yeah.
but they can. And they are using a device that tracks their eye movements to kind of help them communicate. So by looking at like a target, it would read a word or
Yeah.
things like that.
Yeah. And the main thing that needed to like be addressed with this patient was the fact that their caregiver was applying drops to their eyes every 30 to 60 minutes due
I
to
could
their
not
eyes
believe
drying out.
that. I could not believe that.
Yeah. And I hate applying drops even once a day. So I couldn't imagine every like 30 to 60 minutes having
No.
to put drops in my eyes. That's just annoying to remember and
Yes.
everything. But with this patient, if their eyes dried out, then actually that tracking device would stop working and then prohibit them from being able to like
Mm.
communicate effectively.
Okay. So, yeah, I mean, I just can't imagine the burden of one, the patient and their eyes
Yeah.
like getting dried out and uncomfortable that much. But also, I can't imagine the caregiver. Like, most people won't even put in a drop one time a day. So,
Yeah.
30 to 60 minutes, you basically can't do anything. Like,
I know. I know I couldn't imagine having to do that like so often throughout the day. I don't know. That's just a lot.
I know. So, moral of the story that this patient was put into some custom stable elite lenses that they were able to wear for 12 hours a day, which is really good.
Yeah, that's really awesome. And like one other great thing that I think we kind of saw in the case that this doctor did that was
Hmm.
fitting these lenses was had them put like 3 to 4 drops of like a more like viscous kind of preservative free artificial
Yeah.
tear in when they put the lenses in to kind of help
Yeah.
prevent the eyes from drying out.
Like still drying out
Yeah.
more.
Yeah.
When it's that bad, it's, not one thing's going to fix stuff.
Yeah.
So,
Yeah.
but I thought it was really cool. Like they had such a huge improvement
Mm-hmm.
in that patient's quality of life
Yeah.
and they're able to communicate more efficiently.
Yeah.
So it helped ease some of the burden in putting in those drops and also was able to make the patient, live their specific life to the best of their ability.
Yeah, exactly. And imagine like how frustrating it would be to like not be able to communicate.
Yeah, I know. Because then, like, if the eye tracker isn't working, like, were they able to even tell them that their eyes were hurt? Like,
Yeah.
did the caregiver just have to assume, like, I
Yeah.
just need to keep putting in these drops?
Yeah, I guess so. Yeah.
Uh,
And I think this is just like one of those cases too that just makes you feel so good to be an eye doctor and doing
yeah.
what you're doing. Like you really get to understand like how important vision is to
Yes.
people and giving a patient a scleral lens just made literally a world of difference for them.
Yeah, I agree. I mean, that it was a great case.
Yeah.
So if anyone wants to read more about it, visit Valley Contax to kind of read up on it
Yeah.
and a lot of other cool cases on there
Yeah.
as well.
Yeah.
All
Awesome.
right. So I thought that it would be fun for us to talk about some updates in
Mm,
optometry for this episode since we don't have a guest today.
yes. I think that sounds great. I think there's a lot of new things.
Yes, there are. So I thought it would be fun to tackle a topic that is both, board relevant
Mhm.
for
Yep.
students, but also incredibly important in practice. Plaquenil screening and monitoring.
Yeah. And there have actually been some updates to the AAO
Hmm.
recommendations recently,
Yes.
which is kind of exciting.
Hmm.
So we're going to cover the basics first and then talk about what's changed.
Yes, sounds perfect. All right, so let's start at the very beginning.
Yeah.
What exactly is Plaquenil and why are our patients taking it?
So Plaquenil, also known as hydroxychloroquine,
Hmm.
is a medication commonly prescribed for autoimmune diseases like lupus, rheumatoid arthritis, things like that. It's a really great medication for many patients, but because it can cause toxicity to the eyes,
Yes.
optometrists definitely play like a big role in taking care of these patients and monitoring the ones who are on it.
Yeah, for sure.
And when we talk about Plaquenil toxicity, what part of the eye are you most concerned about?
The retina.
The retina.
I don't know why. I don't know why I decided to sing that.
Sometimes singing things just sounds way better.
It sounds more fun. And did I just wake you up?
Yeah.
Okay, so the retina, it's causing damage specifically to the photoreceptors and the RPE. Typically, we think about the damage occurring like in the parafoveal region, but that's actually something else that we'll come back to that was discussed in the updates too.
Yeah, the major point to know is that the damage is irreversible and in some cases can continue to progress even after stopping the medication.
Which sounds super scary.
Yeah.
But I feel like something important for students that are just learning about this to understand is that, our goal isn't to tell patients that and scare them away from taking the medication.
Yeah. Yeah. The benefits of the medication often far outweigh the risk.
Yeah.
And really, our job as eye doctors is to just have early detection and then communicate with that patient's like medical care team. So making sure you're communicating with their primary care, whoever's prescribing that medication.
Yes. Okay. Quick board review time for, I guess, more so part 2 and 3-ish.
Yeah.
When should patients have a baseline eye exam?
Within the first year of starting hydroxychloroquine.
Yes. And when does annual screening start?
Generally, after 5 years, if you're considered low risk.
Yeah.
Although there's some important like nuances we'll talk about when we get into the updated recommendations.
Yeah, for sure.
Biggest risk factor.
Daily dose greater than 5 milligrams per kilogram of patient's actual body weight. So
Yeah.
you need like a scale or to actually have those records from the provider.
Yeah.
No guesstimating here.
Yeah. And I think what was nice about being at a VA hospital is that you have all of that information like readily available to you. So you don't even really have to like ask the patient. And so you can just calculate that, like what their dosage is to, kind of determine if they're at higher risk or not.
Yes.
And what are our other classic risk factors?
So, like I just said, the high daily dose.
Yep.
And then you also want to look at the duration of the use. So, the longer they use it, obviously, the more likely they are to get the toxicity.
Yep.
Kidney disease, if they're concurrently using tamoxifen. Older age, of course. And then any existing retinal disease. And then if a patient has any of these, we would want to start the annual screening earlier than at that 5-year mark.
Yeah, perfect. Okay, so now that we've covered like what Plaquenil is and why it's important, let's talk about the updates because I think this is where things get really interesting. And this is something like it's just crazy that we just learned this not too long ago in school.
I know. And here it is.
Yeah,
changing.
We're getting a change.
Yeah, I agree.
So most of us learned that Plaquenil screening was basically OCT and a 10-2 visual field.
Yep, that was pretty much drilled into us over and over and over again.
Yeah. So one of the biggest takeaways from the updated AAO recommendations is the increased emphasis on OCT and fundus autofluorescence or FAF.
Yeah, for sure. Because, I mean, historically, visual fields were one of the, like, cornerstone screening tests, I guess you would say.
Yeah.
And they are still important, obviously, but the newer recommendations place that greater emphasis on the OCT and the FAF to detect the early structural changes instead of looking more like the functional changes.
Yeah, which makes sense because once patients are already developing these visual field defects, we may already be dealing with like a more advanced toxicity than we'd really like. So,
yeah, exactly. And I just want to talk about FAF real quick for people who may not be as familiar with it because I hadn't really used it very much in kind of my earlier rotations. I started using it more at the end.
Yeah, I think that's a good idea.
So FAF, also known as the fundus autofluorescence, it allows us to evaluate the health of the RPE, and it works by detecting naturally occurring compounds in the retina, which can give us clues about retinal health and function. So it kind of highlights some abnormalities that maybe are too fine to see with a fundus photo or an OCT.
Yeah. So why is there so much more emphasis on FAF in this update?
Yeah, I think one of the biggest reasons is that FAF can sometimes detect those subtle changes before patients even are noticing any symptoms, or like I said, before we're able to see
Yeah.
any obvious findings on clinical exam. So basically, it's just another way to identify any early toxicity.
Yeah. So basically, it's helping us catch changes sooner.
Yeah,
That's what I'm getting.
exactly.
Yeah.
Yeah. So that's like we said earlier, the whole goal of us seeing these patients is early detection.
Yeah.
So once toxicity becomes clinically obvious, the damage is already irreversible, like you said.
Yeah.
So it just basically adds to our like toolbox of being able to
Yeah.
hopefully prevent more patients from getting to that kind of step.
Yeah. And that's really the theme of these like updated recommendations, using imaging to find structural changes as early as possible.
Absolutely. And I just want to point out again, like it's not that the visual fields aren't important anymore
Yeah.
because they definitely are. We do need to still do those. We're
Yeah.
just looking more at OCT and FAF before the patients are symptomatic.
Yeah.
But the visual field will be important to use, if your patient has toxicity and you need to monitor like if it's changing or if they're like how much visual
Yeah.
field they're missing.
Yeah. Yeah. And I think it's just a good reminder that if you're still in school, don't just memorize the screening tests
Yes.
for boards. Understand why we're using them, because that's ultimately what guides our patient care.
Yeah, for sure.
And another thing that kind of stood out to me was the discussion about the paracentral toxicity.
Yeah, same. Because we were taught that parafoveal is like the classic kind of presentation in the area that we're most worried about. But then we did talk about kind of briefly mentioning that in Asian
Yep.
patients, paracentral toxicity is something we need to look out for.
Yeah.
But in the updated recommendations, they actually emphasize that we should be looking for both parafoveal and pericentral patterns in every single patient, which I thought was interesting.
Yeah, that definitely is. And I think that's kind of one of the biggest updates from like the AAO recommendations.
Yeah.
We shouldn't assume that paracentral toxicity is only something to look for in Asian patients anymore. We need to be looking for it in everyone taking this drug. The recommendation is to like actively evaluate for both patterns, regardless of that patient ethnicity.
Yeah, exactly, which is really good because, we shouldn't be only looking for certain diseases and certain types of patients. They should be monitored in everyone, even though, sometimes it is more likely in certain people. Doesn't mean that it's not always, I guess,
it's not always the
not
case.
a word you want to use.
And like they say, it's not rare if it's in your chair.
Yes. Okay, something else I want to talk about for just a moment is I think one misconception students especially have is that they're looking for bullseye maculopathy.
Yeah, that is a really good point. If you're seeing like a classic bullseye maculopathy, that's a little bit of a late finding.
Yes. Because I don't know, I feel like that's all they kind of talk about is like bullseye maculopathy and Plaquenil.
Yep.
But honestly, still, like, I feel like I would have maybe a little bit of a hard time kind of seeing. I think I would see the very start in the retina, and I don't think that my first thought would be kind of bullseye maculopathy.
Yeah.
Obviously, if I know that they're on Plaquenil, then it would, bring up that red flag.
Yeah.
But something that you forget about is that's like, if you see that, then that's it. It's too late. You
Yeah.
have missed your opportunity pretty much.
Yeah.
Which it's something students should remember for boards too. Like bullseye maculopathy is that classic finding.
Yeah.
But in real life, that is not exactly what we're looking for, or that's not what we're monitoring for, I guess you could say.
Yeah.
Which is why the OCT and the FAF have become so important.
Yeah, exactly. And one thing I didn't appreciate as a student is how much communication goes into managing like these patients.
Yes, I did not appreciate that at all until I got on rotation.
Yeah. Yeah. I mean, if you're concerned about toxicity, you don't just tell the patient to stop their medication and send them their way. Like, you can't do that.
No, you cannot, because these patients are relying on that hydroxychloroquine to control like serious autoimmune disease. So imagine if you just told them you have toxicity, stop taking it, and then their entire body just throws up all the flags and it just starts attacking itself.
Yeah. The management involves definitely communicating with the rheumatologist or prescribing physician and making a collaborative decision. This, you can't just like see the first signs of Plaquenil toxicity and be like, yeah, you're off of this. But that's why also it's so important to calculate like the dosing and like how, if they're high risk or not. Because I've known like on rotation, I've had a doctor say that they calculated it and they were over that 5 milligrams per kilogram per day. And they reached out to the prescribing physician and they actually lowered the dose. So it's important.
I have seen that multiple times, or even like if a patient does need to be on kind of a little bit of a higher dose, you can kind of work with the pills and kind of do like where 1 week they're taking a little bit less, the next week they're taking a little bit more to get overall that dose, but it's not so heavy hitting on them like all the time. So kind of understanding all of that. And there is a Plaquenil kind of calculator online too, where you kind of put in their body weight.
Oh, right. Yeah.
And it helps you kind of understand that and calculate it, so you're not pulling out your phone calculator and tapping away. But I feel like the providers really are relying on us to keep them informed if we identify any concerns. So they don't have a way to monitor for retinal toxicity themselves, so this truly becomes a team effort between the patient, the prescribing physician, and the eye care provider.
Which is kind of why I think this is like such an important topic to like kind of talk about.
I know, and I think like one kind of nice thing and like, I don't know, kind of boost my ego a little bit is that like rheumatologists and like providers for patients on Plaquenil, like they know that they kind of need us to be part of that team. So when like you do reach out to them to say, hey, like this is my recommendation, this is what I'm seeing, they're really receptive of like our feedback instead of just like dismissing us and like whatever. So I kind of like working with rheumatologists.
Yeah, they do really like rely on us to make sure that that patient is, their eye health is being taken care of and they're not seeing any like signs of the toxicity. So I know I am kind of like surprised just from what I've seen out on rotations. Like those doctors really do rely on us. And I think it's so important to have those good relationships. And even if that patient has a great report, sending them over like a report, like no toxicity, just letting them know and keeping them updated on, their eye health.
Forming that like communication and like that relationship with them so that when you do say, hey, like we need to alter their dose, they're not like, who are you? I've never heard of you. Like, what are you doing? Kind of like, okay, like, yes, like I trust her, like they've been like looking at them for a long time. So should we kind of finish up this talk with 3 things every student in new grad should remember about Plaquenil?
Yeah, I think that's a good way
just
to kind of wrap things up.
Notes at the end. Yep.
So number 1, dose matters. The goal is still no more than 5 milligrams per kilogram using their actual body weight.
Yes. Number 2, don't wait for bullseye maculopathy to be in your chair. Use that OCT and the FAF to identify those changes early on.
Yep. Number 3, screening is about protecting vision while helping patients stay on medications that can be life-changing for their systemic health.
Yes, absolutely. I think those are 3 great kind of things to keep at the forefront, and then the rest you can dig through the files in your brain later when you see that. So.
Just remember those 3 big takeaways.
Okay. I feel like this episode helped break down both, the basics of Plaquenil screening and kind of updated on those recent recommendations from the AAO, because it's very easy to see that and then say, I'll read it later, and then you don't read it, and then you're, wasting your time doing stuff that you shouldn't be doing.
Yeah. And if you're a student studying for boards, we hope this was a helpful review. And if you're in practice, hopefully it gives you a few pearls to think about next time a Plaquenil patient is in your chair.
Yes. As always, thank you guys for listening. We'll be back for episode 6 with a fun guest, hopefully.
Yes.
If you want to be that guest or guest for any future episodes, please let us know.
Yeah. And episode 6. Gosh, I still can't believe it.
I know.
But don't forget to subscribe and follow us on Instagram at Blink Collective Podcast.
Yes, and we also are on TikTok as well, but that one is just at Blink Collective. There's no podcast on the end of that one.
Yeah. And make sure to share this episode with a friend. And remember,
you do not always have to have it figured out, because we still don't.
Literally, you just have to keep showing up.
Yeah,
We'll see
you next time
on Blink Collective.
Blink Collective.